Good morning, everyone. Thank you very much to the chair for the kind introduction, and thank you very much to the faculty for inviting me and giving me the opportunity of talking about this new era in respiratory treatment targeting the epithelium and TSLP in severe asthma. It is well established that the airway epithelium is the first point of contact for environmental triggers. It is a barrier and a sensor of the environment, but it's also an immune functioning organ capable of mediating immunity and inducing inflammation through the release of epithelial cytokines called alarmins. And through the release of alarmins, epithelium can drive structural changes and airway remodeling, as you will see later on during the presentation. In this very elegant paper published in European Respiratory Journal, it has been highlighted that the epithelium is an orchestrator in the induction and also in the perpetuation of inflammation, and it can be considered a therapeutic target in severe asthma. And supporting this concept, EACI recently revised the nomenclature of allergic diseases, introducing a novel concept of tissue-driven mechanism, talking about type 5 epithelial disease, referring to an immune modulation related to alarmins, TSLP, IL-25, and IL-33. Several environmental exposure can act on the epithelium and induce triggering the release of epithelial cytokines called alarmins. These epithelial cytokines can activate both innate and adaptive responses, and they can induce downstream inflammatory processes. I would like to emphasize that alarmins are a broad family of epithelial cytokines. The most well characterized are TSLP, IL-33, and to a lesser extent IL-25. There is compelling evidence that the airway epithelium is significantly altered in asthma. And as you can see in this transversal section of a bronchus on the right side of an asthmatic patient, in asthma there is epithelial damage. So there is an increased epithelial thickness, a reduction of epithelial tight junction in number and integrity, goblet cells hyperplasia, and increased mucus production. All these features are best known as airway remodeling. So airway remodeling is a multi-step process characterized both by inflammatory and structural changes, as you will see later on. Now I would like to focus your attention on TSLP, which is the most relevant alarmins in asthma. TSLP acts both as an upstream and also a downstream cytokine because it is rapidly released from epithelial cells following several stimuli, for example, allergens, cytokines, viruses, and so on, and can activate a plethora of immune cells of the innate and adaptive immune system. And in particular, TSLP can activate dendritic cells, innate lymphoid cells, type 2, can activate B cells, Th2 cells, eosinophils, neutrophils, mast cells, and as you will see in detail, macrophages. It is important to note that beyond epithelial cells, also other immune cells, such as mast cells, fibroblasts, keratinocytes, and macrophages, can be a relevant source of TSLP. They can contribute to the release of TSLP. We know that inflammation in asthma is complex, it is heterogeneous, and also biomarkers of our patient can vary over time. And given these premises, TSLP, given in its high role in the inflammatory cascade, can be potentially implicated in all the endophenotype of asthma. Several studies have demonstrated that TSLP is associated with multiple clinical features of asthma, and in particular with asthma severity, exacerbation risk, lung function, airway hyperresponsiveness, and airway remodeling. In this important paper by Lee and collaborator, it has been demonstrated that airway TSLP expression is increased in asthmatic patients compared to controls, as you can see from this graph, and also that there is a linear correlation between asthma severity and airway TSLP expression in the bowel of these patients. TSLP has also been associated with an increased exacerbation risk in asthma. In this paper by Co and collaborator, serum TSLP level equal and higher than 25 picograms per ml are associated with a significant risk of exacerbation. In the same paper that I showed you before by Lee and collaborator, airway TSLP concentration correlate with a reduced lung function in patients with asthma. So there is an inverse correlation between respiratory function and TSLP concentration, highlighting a key role for TSLP in respiratory function of asthmatic patients. Airway hyperresponsiveness in this important paper published by the group of Celeste Polsberg. It has been demonstrated that airway hyperresponsiveness correlate with airway TSLP in asthmatic patients, in the sputum of asthmatic patients, and this is independent of eosinophilic inflammation. But TSLP is a small but complex protein which exists in two isoforms, as demonstrated by Arada and collaborators some years ago. So there is a long form, which is upregulated during inflammation, and a short form, which is constitutively expressed at mRNA level. And the short form, as highlighted in green, includes the last 63 amino acids of the C-terminal portion of the long form. And recent evidence suggests that the long form is increased in inflammatory and respiratory diseases. So starting from that, we developed a very sensitive and specific methodology to identify the two TSLP isoforms by mass spectrometry. We identify the specific amino acid sequences for the long form and for the short form, here in the right part of the cartoon. And then we evaluated in a cohort of severe asthmatic patient, the plasma concentration of the long form and the short form. And as you can see here, the results, the long form was increased in asthmatic patients compared to control, whereas the short form is not detectable, neither in healthy donors and severe asthmatics, even using with these sophisticated method techniques. Recently, we verified that beyond epithelial cells, also other preeminent immune cells in the lung, such as macrophages, could be a significant source of TSLP. And I'll show you the results of this paper published in European Journal of Internal Medicine. In figure A, you can see the localization of TSLP. It is localized, this is a confocal microscopy, it is localized in the cytoplasm of the human lung macrophages, whereas the nucleus, which is DAPI blue stained, is negative for TSLP. And these data are confirmed by Western blot and mass spectrometry. So this is the first demonstration that TSLP as a cytoplasmic localization in human lung macrophages. And here, you know that human lung macrophages are very heterogeneous, so this beautiful picture referring to different macrophages studied by confocal microscopy, and in red, the cytoplasmic localization of TSLP. In a second set of the experiment, we demonstrated that T2 high stimuli, such as IL-4 and IL-13, and T2 low stimuli, such as LPS, which is a bacterial product, could be a potent stimulant for TSLP release from human lung macrophages. So here we demonstrated in a previous paper that the IL-4 receptor was present on human lung macrophages, and in B you can see that IL-4 and together with alone and together with IL-13 and LPS can induce a potent stimuli for TSLP release from human lung macrophages, thus suggesting and supporting the centrality of TSLP in asthma, in T2 high and T2 low asthma. Airway remodeling, we already said, is a key feature of asthma. Is characterized by both inflammatory and structural change sustained by inflammatory angiogenesis, so the formation of new blood vessels, as highlighted in this collaboratory paper. And alarmins play a key role in airway remodeling, and in particular TSLP, you can see here, can activate fibroblasts and producing collagen, induces epithelial mesenchymal transition, and the upregulation of transforming growth factor beta, promoting the proliferation of airway smooth muscle cells and the proliferation of epithelial cells. But let's see how TSLP is involved in mucus plugin production. We all know that mucus plugin is a detrimental feature in severe asthma, and it is associated with increased risk of exacerbations and decline of FEV1 over 5 years. And the role of TSLP mucus plug formation is dual, at least dual, because from one side, TSLP can activate Th2 cells, that produce IL-5 that activate the eosinophils. An eosinophil can produce reactive oxygen species and eosinophil peroxidase, which increase the viscosity of mucus. And on the other side, TSLP can activate innate lymphoid cells type 2, inducing the release of IL-5, and IL-5 activate eosinophils. Eosinophil can produce eosinophil extracellular traps and can also produce galactin-10, which can precipitate in the lung, forming Charcot-Leyden crystal. And that in turn can induce net formation. So it is very intricate and complicated mechanism and fascinated mechanism through which TSLP induce mucus plug formation in asthma. Now, we said that angiogenesis sustained airway remodeling. In this historical paper, Oshino and collaborator demonstrated that in patients with asthma, there is an increased angiogenesis, inflammatory angiogenesis, which is correlated with the production of angiogenic factors. And given these premises, we evaluated the release of vascular endothelial growth factor A, which is the most potent angiogenic factor from human lung macrophages. And as you can see from the result, the red bar is the long form and the blue bar is the short form. Only the long form can activate human lung macrophages, whereas the short form doesn't have any effect and does not antagonize the activating property of the long form TSLP. So the hypothesis is that T2 high and T2 low stimuli can induce a rapid release of TSLP from the cytoplasm of human lung macrophages, and TSLP can feedback its heterodimeric receptor, inducing the release of angiogenic factor such as VEGF-A. VEGF-A induces angiogenesis, which sustain airway remodeling. And finally, I would like to show you some preliminary data from our group demonstrated that TSLP can directly activate eosinophils of asthmatic patients in inducing angiogenesis and in producing vascular endothelial growth factor A. And as you can see, the long form, but not the short form, induced the release of this important angiogenic factor from human eosinophil of asthmatic patients. And supporting these data is the last, this is a group of very recent experiment demonstrated that TSLP induces also the production of reactive oxygen species from eosinophils of patients with asthma. We know that ROS are involved in mucus production, but ROS are also potent angiogenic factors. So they can contribute to angiogenesis. And there is, in this experiment, a dose-dependent production of ROS from eosinophils of asthmatic patients. So it is not surprising that tezepelumab, which is a first-in-class anti-TSLP monoclonal antibody, is effective in reducing exacerbation until 80%, and improving FEV1 in randomized clinical trials. And as demonstrated in this collaboratory paper published in Allergy, tezepelumab has an effect on different aspects of airway remodeling. So it can reduce airway eosinophil inflammation, also reduce the airway hyperresponsiveness to mannitol, improve a parameter which is a CT scan determined lumen area. in conclusion, we are on the edge of a new era in which airway remodeling epithelium are the present and the future target for asthmatic patients. And in this context, tezepelumab represents a progenitor of monoclonal antibodies anti-alarmins, which had so far very good safety profile and showed a very good efficacy in randomized clinical trial. And so we are waiting for the real-life data. The first seems to be overlapping to randomized clinical trials. And I would like to thank you, everyone, for the attention. And of course, I would like to thank you, all my groups in Naples. Thank you.